The first one, we've got speakers from Tenebus. We'd like to welcome Maddie Young. We've got Dr. Ruth Corbley, who's one of the GP leads in Paris Health Board, and hopefully Dr. Hassan Haboubi, who's a Cardiff and Vale gastroenterologist as well, who we hope will be joining the meeting shortly. In terms of questions and answering, I'm happy for people to write a message in the chat rather than interrupt the flow unless it's a really pressing question, in which case put your hand up. And then I'll keep an eye on the chat and I'll interject, and then hopefully there might be a bit of chance for Q&A at the end. I do have just a quick welcome slide to share, but actually I think I've covered most of it. So I might, if that's okay, move straight on to Maddie, please. Thanks, Maddie.
That's great. Hello. Hopefully you can see those slides now. So hello, I'm Maddie Young. I am Insight Lead at Velindre Cancer Care. And thank you very much for giving me the opportunity to chat to you tonight. If you haven't got any sort of understanding of what Velindre Cancer Care is, hopefully you've heard of us. We are Wales's largest cancer care charity, and we have a wide variety of activities. We try to support people in all stages of their cancer journey through benefits advice service, through our counselling service, which isn't just for people who have been directly affected by cancer, but also for their friends and family. We have a nurse-led support line, which offers practical advice about cancer symptoms, but also response to chemotherapy and side effects. We have our All Wales Cancer community, which is made up of people who have been affected by cancer and want to use their voice and experience to change services and research for the better. And we have our supportive services like Sing With Us, which is local choirs to support people who have been affected by cancer. So why am I speaking to you today? Well, although Velindre Cancer Care supports people affected by any type of cancer, we're not a tumour-specific cancer charity. We do have priorities, and one of our priorities is working in the area of the less survivable cancers. When we looked at these 6 less survivable cancers in Wales and the service that is provided for these 6 less survivable cancers, we realised that esophageal and stomach cancer are particularly poorly served by the third sector. And so NHS Wales is lacking in that area because there isn't that third sector support for those cancer types. So we decided that might be something that we could add value into the space. And so the first thing we did was actually try and look at what the situation was. We didn't want to come in as completely non-experts. So we wrote a report 2 years ago called A Burning Issue. And this was based off the back of a group meeting with all sorts of different people from all sorts of different fields to try and identify what the main problems were with late diagnosis of esophageal and stomach cancer in Wales. And we then did this sort of research project in-house and came up with these we tried to identify the problems first of all. A lot of these problems we already know, but this was sort of putting a label on it, trying to make it in a format in this report that could be shareable and usable by people such as yourselves trying to make change. But obviously we identified the problems that you probably would be aware of, like endoscopy waiting times, the differences between health boards, the dramatic difference in emergency presentation between of esophageal and stomach cancer patients in different health boards. All this adds up to this late diagnosis. It falls under the late diagnosis umbrella. And we also started talking about Barrett's esophagus monitoring. Now, one thing that we really want to do is sort of dig a little bit deeper than other people might have opportunity to. As a third sector organisation, we have a little bit of flexibility around that. We've got the time and the resources to try and sort of get our teeth into things sometimes. And so we started looking at this Barrett's esophagus problem. As you know, Barrett's esophagus is sort of the known precursor of esophageal cancer. And it's estimated that 3% of people who are diagnosed with Barrett's esophagus will go on to develop esophageal cancer. And of that group of people, if they are receiving regular endoscopic surveillance, then they have a 30% reduction in mortality. Now, we wanted to look at it from a slightly different angle. With all sorts of screening programs, the idea is about identifying a population who are particularly at risk. And that's what Barrett's esophagus enables us to do. So we started asking, what is the actual number of people who have been diagnosed with esophageal cancer who have previously been diagnosed with Barrett's? So it's coming at it from a just slightly different angle. So we put in these freedom of information requests, we had a look at all the available data that we could get access to, and only 2 of the health boards could actually provide us with that data. The rest, it just wasn't available. Of those 2 health boards, we saw that it was somewhere between like 25 and 30% of esophageal cancer cases had previously been diagnosed with Barrett's esophagus and were undergoing regular surveillance. But this didn't translate into early diagnosis. So we asked the question about how is surveillance being measured and recorded? Because it really needs to be if it's not translating into early diagnosis for those patients. And the answer was, we can't find that data. It's not accessible, or it's not in a format that can be interrogated easily. And so we started thinking that actually needs to be a priority in this field. So our recommendations out of this report came to be increased symptom awareness, particularly in areas of high deprivation in Wales, where symptom awareness of these cancer types is incredibly low. Increase the capacity of endoscopy surfaces in Wales, but particularly focusing on new technologies and techniques such as transnasal endoscopy and the swallowable sponge test, which we will hear more about later, so I won't go into too much detail. And thirdly, it was to create a national registry for people with Barrett's esophagus in Wales, because it currently doesn't exist. Now, again, because we are a third sector organisation, we have a huge amount of flexibility, and we decided pointing out these problems is all well and good, but let's see what we can do about them. And so our first step was to try and act on increasing public awareness of the symptoms of esophageal and stomach cancer. And our comms team came up with this great campaign, which was called Life Shouldn't Be Hard to Swallow. And we decided to target that campaign through pharmacies, social media and content marketing. Now, whilst I've said all of this stuff about flexibility, we are still limited by funds. We are a charity, and we can't spend all our money on raising public awareness. But we thought, so we needed to be targeted. And so we decided to target the most deprived areas in Wales, where we know symptom awareness is lower. We produced these pharmacist information packs. There's about 670 odd pharmacies in Wales, something along those lines. We couldn't contact all of them. So using mapping, we were able to identify the pharmacies that were in the most deprived quintile of Wales, with really poor access to services. And we targeted those. We phoned every single one of them. It was about 100 odd pharmacies. And we sent them an information pack for their pharmacists to how to talk to people who are buying over-the-counter heartburn or other medication for gastric problems, and little postcards that could go in the purchasing bag. So when someone did buy some of that medication, say they bought Gaviscon, they also got a card with the symptom awareness then. This actually translated really well into people linking through. It had a QR code to link through onto our website, and we had more than 1,000 people from that actually come to our website to read more about the symptoms. So the appetite is there. We also had a social media campaign, and we'll hear more from Hassan in a bit, but Hassan did a really great job, made a video for us about symptom awareness, and about what you should do if you experience any of these symptoms. This was seen these were our targeted Facebook ads, again, to the more deprived areas in Wales, seen by about more than 82,000 people. 2,000 of them clicked on the link to find out more from our website. Now, for a symptom awareness campaign, that's a pretty good turnover rate. It worked out as about 19p per click for us, which, again, in these really normally underserved communities, is actually a really good value from our point of view. The video from Hassan was actually the most, the most popular one, so well done. And also it's really great to know that when you do engage with charities and things like this, it does actually really work. We also had a content marketing into sort of local areas, and a lot of our social media and content marketing stuff was shared by MSs and got the backing of lots of different people from all sorts of different walks of life. One thing I will say about this content marketing, I don't mean to blow my own trumpet with this, but the click-through rates were really, really above the market average, which shows that there's just an appetite for this. People genuinely want to know and they want to know about the symptoms. We were fortunate that we had a brilliant case study of this wonderful lady, Christine, who had experienced difficulty swallowing for more than a year before she went to her GP about it. And it got to the stage where she could barely swallow water before she even thought to go to her GP about it. And so she was really, really great. And obviously that story really resonated with people. So beyond that, we've also had activity in trying to increase and expand the capacity of endoscopy services. A lot of that is through our policy team. And thank you to anyone who has engaged with that work. We've got buy-in from lots of different, it's now part of our manifesto. And we've had buy-in from lots of potential MSs already. We also, as I said, the Barrett's esophagus registry, it's not where we would like it to be, but we have had lots of conversations with the Wales Cancer Network about whether the new cancer informatics system can actually, or solution can actually capture a lot of that data in a much more interrogatable fashion, so that we can look at better understanding how many people are being diagnosed with Barrett's, at what sort of severity of Barrett's it is, and how long it is between surveillance. So that will give us a lot more information moving forward. And if it turns out that that implementation doesn't take place, we will be trying to get answers and reassurances about that. I am just going to talk for one more minute, if that's okay, about something that's come off the back of that. So I mentioned the All Wales Cancer community. And this is another example of how we want to be able, as 10 of us, we actually want to be able to support yourselves in your roles. And one thing we ask the people when they join the All Wales Cancer community is, what one thing do you wish you'd known at the beginning of your cancer journey? And one thing that comes up time and time again is, I wish I'd known what to ask and how to talk to my GP. And that could be, quite often, it's people saying, well, I had symptoms and I went to the GP and I was worried about cancer, but I came away not reassured. And when you question it, it's because the word cancer was never mentioned. No, they went there worried about symptoms, but they didn't say, I'm worried about cancer. So they went away not reassured, and then went back again the next week, and then went back again the next week. And it took much longer for them to even have the conversation of, well, it's really unlikely to be cancer, and put their minds at rest, or to try and have the discussion about referral forward. So we produced these vague symptom checklists, which are not diagnostic in any way, shape or form, but they are there to support patients coming to yourselves. And if they're not comfortable saying the word cancer, then we'll say it for them on this checklist, and then they can have that conversation. And these checklists not just include what the vague symptoms are that they're experiencing, but also some questions they might want to ask. How do you know that it's not cancer? That sort of thing. Now, we've received a lot of really positive feedback on these forms, but specifically from patients. They've been received really well from patients. I'd love to hear your viewpoints on them. as well, particularly since we have had them translated into Arabic and Polish, the most commonly used languages outside of English and Welsh. And they're being used reasonably well within some of the Arabic communities in Wales, where they're worried that they'd normally have to take a family member with them to an appointment if their English isn't, if they're not fluent in English. And when it's really personal and private symptoms, they don't feel comfortable doing that. And we've heard from them. They're feeling really positive about it, but I'd love to know what you guys think about that as well. How you would feel if someone came in to your practice with one of these checklists to talk things through with you, and if you would like to change it in any way. These are available on the Tenebus website. I can share them afterwards as well if you want to see them. So yeah, that's all I really wanted to talk about. Thank you very much, and happy to take some questions.
That's really helpful. Thanks, Maddie. I mean, I think first in line as a GP to come straight back at you with your question about, you know, your checklist thing. I mean, I think actually raising awareness of lesser heard and sort of maybe more ignored symptoms is a really good point. And I think as a start for a conversation, it's a good one. I think probably all the GPs on the line, when they see a patient come in with a list, you know, there is a sort of heart sinks, a moment of dread. But actually, if it's sort of like that table where it's like, actually, this is my problem, and advice about how to speak to it rather than sort of ticking all the boxes, although obviously if there is a significant concern that something going wrong. So I think to open a conversation, it's a good idea. I don't know if anyone would like to put their hand up and come in on that immediately. I know that there are a lot of GPs on the line, but whether they just want to reflect on that or put a comment in the chat. I think it's, you know, something that we hear back in my work with Macmillan as well, that, you know, seeing stuff in other languages is helpful. So particularly where people may need a translator or stuff. I don't know if there's plans to translate into more languages or whether it's just, you know, sort of try it and see for now and see what the take-up's like. But certainly I think for colleagues who work in areas where they have large populations of Polish or Arabic patients, it would be useful to have copies of that available potentially, you know, on reception desks or otherwise.
Yeah, that's great. We are planning to open it out to more languages. We're still in the sort of receiving feedback from both patients and GPs as well stage, so we can adjust as much as possible at this stage before we expand it too far.
Yeah, we have you know, GP committees and things we can share it with as well down the line. It'd be great if you would, while maybe Dr. Haboubi speaking, pop a link to the where we can find it in the chat so people can have a look through and maybe then directly message you if there's feedback specific they'd like to pass on to you, or yeah, very welcome to come back through me if that's something I'm happy to collate if people don't want to come back straight to you. But I think that'd be really useful. I think for all of us, you know, we all have plenty of patients we know on Barrett surveillance, and kind of that sort of trusting the system to mop them up a bit is what kind of makes us nervous. You know, that there will be a rescope, which I imagine sort of Hassan will talk about down the line as well. But I think it's a eye-opening piece of work you've done in terms of what, you know, what follow-up is needed and what we need to be doing, and even in terms of just raising awareness of symptoms. That's really helpful. The audience are particularly quiet, but that's fine because we're you know, at the end of a long day and we're all here for education. So I'm happy to talk or get people to speak with you rather than you know, particularly be too dynamic. But thank you, Maddie. And really, you know, really helpful and great to work with Tenebus, and just raising awareness to everyone on the call and to your colleagues as well that Tenebus exists, and that you know, it's a useful source of support for patients and for ourselves for information as well. And Maddie, I think you're planning on staying on the line till the end of the call, is that right? So if questions do come up, you'll be absolutely, you'll be around to the end of the call.
That's brilliant. Lovely. Yeah, definitely. Thanks very much.
Thank you. So yeah, apologies to Dr. Haboubi because I think there's a couple of call links for this, as in 2 invites were sent out, and I could see you on the other invite when we started the meeting. But I'm very, very relieved to see that you are here, because I'm sure you'll do a much better job at your presentation than any of us would. But yeah, to introduce to you next then, folks, we've got Dr. Haboubi, who's one of the, as the slide shows, one of our consultant colleagues here in Cardiff and Vale, gastroenterologist, to do us an update on GI cancer from a primary care perspective. Can I pass to you, Hassan? Thank you.
Thank you. You can hear me okay?
All good, yes, thank you.
Yeah, good. All right, sorry, I was in another meeting just before this and my microphone failed, and I thought, God, this is going to be a disaster. But anyway, it'll be fine. I can share my screen, but if I do, I lose visual of you, which is not a problem. I guess if someone wants to interrupt me anyway, anytime, that's absolutely fine. Obviously, I can't see any comments. But anyway, if you can see my...
Yeah, I'm happy to keep an eye on the chat, Hassan, and then can interrupt you if there are hands up or anything. But otherwise, yeah, I'm happy for you to run through, and then we'll take questions at the end. But I will keep an eye on the chat and interrupt you if necessary.
Amazing.
That's great.
Okay, cool.
Thank you.
Right. And so you can see my slides. Okay. Let's go into chat mode. Okay. Hopefully you can see that.
Yeah, we can still see your sort of side panel of the next slide, but we can see your presentation, so that's fine.
Yeah, I don't have any comments or notes. So
That's okay. Thank you.
I'm not going to be reading. I don't mind. You can see when I'm getting closer to the end. Maybe it's a good thing to have it. Or do you want me to see if I can try and share it? If I do that, there we go. That's perfect. Better. Okay, right. So thank you so much for the invitation. It's a pleasure to be talking to you this evening. I'm very happy to talk about all things upper GI. I am, I think, still the only upper GI gastroenterologist in the whole of Wales, sadly. But so my colleagues look after upper GI symptoms. It's just I have a very dedicated interest in this area. So very happy to chat now. Afterwards, emails. You'll realise I'm a pretty approachable guy. But Maddie probably set the scene very nicely. I know she talks a lot about these kind of really poorly performing cancers, and I know that's why 10 of us certainly have had a real focus on esophageal cancer and gastric cancer. And this is some of the data behind that. So just to kind of walk you through some of this data, these are arrows. This is old data, but actually, sadly, I don't think it's changed. So this looks at the kind of beginning of the arrow is 1995 to 99, and then the end of the arrow is 2010 to 2014. And what you can see is the improvement in survival from a starting point to an end point over that period in time. So you see Australia does pretty well. North America does okay. You've got parts of Europe that do okay. This is Wales. And you can just work out where we are. And I promise you, we really haven't changed much even since 2014, the last decade or so. So this is where we are in terms of survival of esophageal and gastric cancer. We certainly are one of the poorest performing countries in the world. And actually, what's also very depressing about all of this is the net improvement in that period in time compared to other parts of the world. And as I say, that pretty much is the same for both esophageal and gastric cancer. And when I got into all of this work, many of you colleagues in primary care probably know that when you send a referral to gastroenterology colleagues, depending on who you send the referral to, you get a varied response, I guess. So some people will say, yeah, that's fine, we'll do a USC endoscopy. Some people will say no, and this is a real frustrating thing, I think, for me and maybe for all of us. Sometimes when we put up the barriers a bit, I think that's usually just a reflection of the stresses that we're all going under. And some people give you some helpful advice, but really it's still a bit dismissive and maybe not as helpful as for your patients. And I guess I was reflecting on all of this because in my mind, as an upper GI enthusiast, I was thinking life is simple, right? Someone has some upper GI symptoms, they get an endoscopy, and that's the kind of rule that we should probably follow. This is declared currently as the gold standard test, endoscopy. Ruth will tell you about all the amazing work happening across Wales under her watch that may actually show that endoscopy isn't always the gold standard test. But anyway, the drive behind all of this was, yes, we need more endoscopies. And so there was lots of stuff that were pushing for that over the last few years. And then the reason why gastroenterologists became so defensive in terms of endoscopy was COVID. COVID's got a lot of bad things associated with it. Maybe one of the bad things as well is that we've all become very reliant on these kind of more virtual meetings. I remember a time when it was nice to kind of catch up and have a meal together as primary, secondary care colleagues. But anyway, COVID caused all services to get decimated, including endoscopy. And then it really, I don't think in many ways has recovered, sadly. This was the period pre-COVID and post-COVID. So we've caught up now. Our focus of endoscopy dropped during COVID. But what you can see that's happened, and I'll just bring your attention really to the percentages rather than the real numbers, is that we've changed our focus a little bit. The emergency cases seem to be going up. I think those emergencies always existed. It's just that maybe people are presenting now more as an emergency. This is English data, so when they say urgent, we're talking about our kind of USC 2-week wait type pathway. What's happened a lot of, though, is that our surveillance patients and our routine patients have dropped. They've halved. And we used to have a better balance of those cases. And I think more and more, we mentioned Barrett's. I don't have any specific Barrett slides apart from to say that Ruth might have some of the answers with capsule sponge. But certainly Barrett surveillance has been a problem. And I've had many letters recently from primary care colleagues asking me, this patient's desperate to know what's happening with their Barrett's. I think the Barrett's registry that Maddie mentioned will be really helpful, because I think we're doing a lot of these patients with pre-malignant conditions a disservice. I've had permission from my health board to share our dirty laundry. This is the kind of thing that maybe we haven't articulated to you, but we should. And this isn't just a Cardiff problem. This is a probably an all Wales problem and an all UK problem, although there are pockets of better work and pockets of worse work. So this is it. This is the kind of data that we're very aware of, and I think you guys in primary care probably are increasingly becoming aware of. You don't need to worry unless you're particularly interested in what's happening for your patients awaiting a surveillance sigmoidoscopy. But let's just go to demand in Cardiff and Vale. So we need to perform 20,000 procedures, and our activity is 15,000. So we're just accumulating patients, and we're kind of spiraling a little bit out of control right now. That's really depressing for us in gastroenterology. I'm sure all of you right now are thinking, oh my God, what is going to happen to my patient that I'm sending through to you? I guess there are some opportunities at the end, which I'm sure that's why we've ordered our talks in this way, so that you can kind of see where we may be going. So anyway, capacity just can't keep up with the demand. So a lot of what we in gastroenterology currently are trying to do, we're trying to think a little bit more cleverly. This is a slide from one of my good friends. If you ever meet any gastroenterologists on a very national, international level, you'll hear of a chap called Nigel Trudgill, who's well known for two things he's doing in the upper GI forum across the UK. One of them is to raise the awareness of a condition known as, or a phenomenon known as PUGIC, post-endoscopy upper GI cancers. So he's the England lead. I'm currently the Wales lead. So these are patients who come in, have an endoscopy. We tell them that it's okay. They go away, and sadly, within the 3-year period afterwards, they develop a cancer. We know that pretty much all upper GI cancers have a pre-malignant stage. In other words, we think probably something was missed in their first endoscopy. That might be related to the endoscopist. That might be because of the kit that they were using on the day was a bit faulty. It clearly could be that the patient was very uncomfortable on the day. There were lots of secretions or food. The procedure was more rushed. But anyway, there's that aspect that Nigel's doing. He's also doing some work to see if we can work more cleverly in identifying which patients would really benefit from an endoscopy and which ones still need a test. But because the yield and the requirement for endoscopy is lower in that group of patients, can we be more clever in our use of kind of other adjunctive things? And what you'll see here, color-coded, the esophagus and the gastroesophageal junction is the real problem. It's where the majority of our cancers and pre-malignant conditions occur. The stomach a little bit, but actually we don't need to worry so much about the duodenum. And that's important, that's helpful for us in terms of these kind of adjunctive tests that we might be considering. And this is some of the data that I'm going to present behind some of that rationale and some of the thought process behind what Nigel's driving really across England. I've been I wouldn't really say I'm driving it. I've been gifted this as something that I need to help with. This is one of the bits of data that again really provokes all of this. This is all all UK data, but actually Wales contributes very poorly to the national endoscopy data, or did contribute very poorly to the national endoscopy database. We're a little bit better now. So again, this is more England skewed data, but you'll get the feel of things of what I'm showing you here. This is the percentage of patients undergoing an endoscopy. So obviously that's everyone 100%. And you can see that 16% of patients were in the age range 18 to 40 and 14% were in the age range 40 to 50. But actually, as we all know, age is really important in terms of cancer and kind of use of services. And they make up a very small percentage of the cancer diagnoses. So I guess that's what's going to drive some of the changes I'm aware of. I think some of you may have heard of. I wanted to use this as a forum to really discuss things that I think are happening on a national or international level, which almost might be a little bit out of our control, and how we might be able to work together on some of this. So if we take some of these symptoms, this is that same paper by Beaton and colleagues, but spelt out based on symptoms. So if we look at dysphagia, again, we know dysphagia is a problem, but actually is a problem. So if we look at firstly under 50s, younger patients, in women with dysphagia makes up 0.3% of cancer diagnosis. In men, it's 0.85. So men, we know, upper GI diseases is a male predominant disease, and there's some really interesting genetics reasons for that, and hormonal reasons for that as well. But certainly age, can be used to risk stratify patients. So what do we do currently? I guess before I talk a little bit about what may be coming. I've put NICE guidelines, I've put some Scottish guidelines, I've put some Northern Ireland guidelines. I think we're all still pretty much following NICE. As you know, we say age more than 55, weight loss, and then maybe some other adjunctive or some other symptoms, epigastric pain, reflux, dyspepsia, and so on. Weight loss is something that has been described variably, I think, between primary care communities, secondary care communities, epidemiology communities, charities. Everyone, I think, has a slightly different definition of weight loss and what they would deem to be relevant. That's really frustrating. We can't all agree. But anyway, here we are together. So I'll tell you, I guess, a little bit about the terms that have been used in the studies and the kind of terms that we in secondary care probably need to know about a little bit more. You'll know about the 5% weight loss over a period of time that I guess sometimes is used for referral to the RDCs. We tend to, in secondary care, like to define significant weight loss over a period of 6 to 12 months. And I was thinking about that, and I know that's potentially very relevant in terms of a cancer diagnosis, but actually, if you left a cancer for 6 to 12 months, we probably have missed the boat. And looking back at that epidemiological data that shows the really feeble increase in improvement of mortality rates in the Welsh population, I do wonder whether we are maybe holding back a little bit on investigation. And then this term that sometimes is thrown around about rapid weight loss, which I think is relevant, the kind of the 1 kilogram per week weight loss, I guess. That is certainly relevant. Obviously, 1 week isn't really a sufficient time period to monitor someone's weight loss. There is some data. Nigel Trudgill led on that data, or maybe he didn't, but it was a kind of Midlands group of colleagues that led on that data that looked at kind of at a 3-week period. So I guess they added that up and they said 3 kilograms, just as another kind of definition of weight loss in that period of time. You'll know about some of these other, you know more about NG12 than I do, certainly. So upper abdominal pain with anemia. I guess the only other thing that we don't mention enough of is raised platelet count. And I think I've seen a few cases. I'm going to show you a case a little bit later on where actually this patient had a raised platelet count. And I kind of thought about, well, maybe we didn't look at that. I think it's important. It seems to be very important in the stomach. As I said, the duodenum you don't need to worry about from an upper GI perspective, and maybe less so in the esophagus. But then there may be something in the raised platelet count. And then I'm going to mention a little bit about gastric later, although if I'm known for anything, it's the esophagus. about Helicobacter pylori testing. And again, I think maybe we're doing our patients a little bit of a disservice with some of the H. pylori testing. I'm hoping I can reassure you a little bit on that a bit later. This is patients under the age of 50. I told you this. This is the data that I think is driving a lot of change currently in England. There isn't a little marker for Wales yet, but I think more and more there is consideration of this. These dysphagia scores. So can we identify the patients that really are going to benefit from their USC 2-week wait endoscopy, and actually then can we do other tests? They still need to be investigated, but probably can we find an alternative test for a group of patients maybe with a lower dysphagia score? There was a lot of work that was done during COVID for something you may have heard of, the Edinburgh Dysphagia Score, the EDS, which I've lined up next to what I think is coming through across I say the whole UK really, the CDS, the Cancer Dysphagia Score. And just walking you through these, well, we all know age is a really important factor behind cancer diagnosis. As I mentioned, there's something about being male. It was 2 parts of my PhD thesis looking at the hormonal aspect of Barrett's esophagus. I got to sprinkle estrogen on cells. I thought it was fun at the time, but anyway, and we could see that there was a protective element to estrogen. That's really important actually, because we worry about men at 50, 55. Clearly, as women go through the menopause, that changes, but they're kind of delayed in terms of their risk of developing cancer by probably a decade or so. So that's why a lot of us say, men 55, women 65 and older, but maybe thinking of a similar kind of age range. This is where the number of 3 kilograms comes from. It was from that collaboration. So unintentional weight loss more than 3 kilograms. And that gives you a very high score for the cancer dysphagia score and a reasonable score for the EDS. And then sometimes our patients present with long symptoms, and there are a whole load of benign conditions that give you dysphagia. Most commonly in the young patient group, it's eosinophilic esophagitis. It could be achalasia. It could be reflux-induced strictures and so on. But I think if someone's symptoms have been going on for more than 6 months, probably, unless they've got significant other symptoms that will score, you can remove some points. So they get a minus point there. There's something really interesting from a study that I'll share with you later about localization of dysphagia to the neck. And what you can see on this slide is that they get negative points for localizing dysphagia to the neck. In other words, it seems to be a less sinister finding for esophageal cancer. Now, obviously, there are patients who have pharyngeal pathology, so I bear that in mind. But this is very much from a dysphagia esophageal type problem. If people have long-standing reflux symptoms, again, actually there's something very interesting. Barrett's is a phenomenon that that actually is it's a natural phenomenon to deal with heartburn. And a lot of patients that present to us with Barrett say, well, I don't have heartburn. Why are you flogging me with PPIs? And why are you asking my GP to keep on giving me PPIs? I don't have any heartburn. Something happens to these patients, and the columnar mucosa is less sensitive to the effects of reflux. So, we're always aware of these patients with silent reflux. So if they do have reflux, sometimes actually they haven't really developed the Barrett's and then the cancer after that. And progressive dysphagia, we all know, is a very worrying sign. So you tot up these scores, and that's what happened in a lot of these studies. I don't need to bore you with the stats really, apart from to say that 5.5, and you can see this isn't hard to work out someone's age, their gender, to ask them if they've lost 3 kilograms, if their symptoms have been more than 6 months. Do you have any heartburn symptoms? Have your symptoms been progressive? And where the dysphagia is localized to your neck. We do it. I do it for some of my referrals. We could get through this in about a minute and a half. And 5.5 seems to be the magic number that has a really good sensitivity and specificity. This pharyngeal level or throat level dysphagia comes from this study, and there was a really old study that was done. I'm a fan of kind of history of medicine, and it was done on medical students. I guess you could get away with that in the 1940s or 50s. They got some medical students and they put a balloon in their esophagus and they inflated it until they caused pain, which clearly you can't get away with doing that now. And they asked the medical students where to point, and basically the location of dysphagia is pretty poor. people were pointing and they were getting it right only a third of the time. And this is a more robust, up-to-date study that probably doesn't break any ethical boundaries, looking again at where people localize symptoms. And actually, they do get it right with high-level dysphagia. They're more likely to identify it in the throat. But actually, unless they have other pharyngeal symptoms, they were unlikely to have an esophageal cancer in that patient group. Whereas actually, if they pointed lower down, they might get it wrong. So pharyngeal level dysphagia seems to be, or throat level dysphagia seems to be a more reassuring thing, so long as they don't have any other oropharyngeal symptoms, difficulty in initiating swallowing, clearing secretions, and so on. And I guess then the other thing is, well, what can we do for these patients? If you're telling me they're very reassuring, could we do something like a barium? And I guess this is a study which looked at this. This is from the Mayo Clinic. And I guess if you're a radiologist in the Mayo Clinic, you probably are very good at your job, or at least probably very good at publishing, maybe, I don't know. And they looked at these different types of strictures. You can see things that you and I may have seen many years ago described as apple core strictures, and we all get worried about that, and maybe more smoother looking strictures and so on. The Mayo Clinic world expert radiologists got it right only 50% of the time. And so that's why one of my colleagues, Ruth Ellis Owen, keeps on saying, look, please don't do a barium swallow for patients with esophageal type symptoms or dysphagia. There may be a role for high throat level dysphagia. So if someone's pointing to their throat, a barium may be helpful, and then potentially a referral to ENT. But if we're looking for esophageal cancer, we'll get it wrong. So we need to do better. We don't have enough endoscopy. A scoring system may help us, but whilst we're waiting, could we do a barium for the others? Probably not. A barium is not going to be helpful there. Ruth will give you the answers for that, but let me just go through some of the other things in this study. So dyspepsia, the chances of dyspepsia alone in a very young group of patients, even if they're men, less than 50, developing cancer or finding a cancer is less than 0.1%, 0.08%. I think more and more we're aware of patients that have functional dyspepsia, but that I think really is a diagnosis of exclusion. The BSG have made these guidelines and said, look, if someone has obviously got weight loss, don't worry about that. But actually, if they have postprandial fullness, early satiety, and epigastric pain, burning pain for 8 weeks, could be postprandial fullness, I still have to question these guidelines and think but checking for H. pylori, I think, is really important. And what I wanted to reassure you all about H. pylori testing is that patients with Helicobacter pylori, even if they're on a PPI, the PPI reduces the chances. I know we all say, oh, they're on a PPI, so no point doing a stool antigen. But actually, even if we do a stool antigen, the chances of getting a positive H. pylori stool antigen is around about 40%. So PPI does reduce it by about maybe 60% or so. I don't know. I mean, it's not a 100% sensitive test anyway, but it doesn't completely eliminate it. So I don't think we do enough stool antigens in secondary care, and I guess I wanted to use this as a platform to reassure you all in primary care that it doesn't obliterate that, and we might be able to do something about that. This is a case which I guess I wanted to demonstrate of a patient who had some fullness and some early satiety, no weight loss, a youngish patient, I think, again in their 50s, and had this endoscopy. This is their upper stomach, looks okay. This is their stomach leading to the pylorus and then the entry into the duodenum down here. I think you can all see, you don't really need to be a gastroenterologist to see some inflammatory change. There is some kind of lumpy bumpiness here on the right hand side of that inflammatory change, but actually, I mean, it's smooth and it looks pretty benign looking, and I don't think any of us would say that's anything abnormal. So that was an endoscopy. The patient had a Clow test, it was positive. And then they had some biopsies. The biopsies showed, this is the histology, so some focal intestinal metaplasia. Metaplasia is a change in the lining, and can be a I guess a pre-malignant condition, not just for Barrett's, but intestinal metaplasia can also be something that we worry about in the stomach. But anyway, the patient had some Helicobacter pylori eradication. As with all things now in gastroenterology, you get this letter from us saying apologies for the delay in writing, because we're just not very good at doing endoscopies or writing to the patients with the histology. And then what I think, if you get a letter from me or an endoscopy report from me, I'm more and more now asking you to check, if you can, a stool antigen in the community after the patients had their Helicobacter eradication, to see that they truly are eradicated. I think we're just seeing more clarithromycin resistant, certainly, but maybe multi-drug resistant H. pylori. You know where this story is going, sadly. So the patient, there was no advice even to check H. pylori eradication. The patient comes back. And this is the patient's endoscopy now, and this is not long ago, and this now has changed. You can see that it's looking a little bit more irregular and more lumpy bumpy, and so what was a very pre-malignant condition not long before now really is looking a little bit more abnormal. So there we go. There's the before and there's the after. This was an early gastric cancer. And we don't see many early gastric cancers, but this is usually the kind of thing that I'd be sharpening my endoscopic knives for. But the ulceration tells me that this is, and that little white depressed area there tells me this has just gone into the submucosal layer, so it's not truly mucosal. And this patient has had a gastrectomy, and that's a real shame that we reached that point from this very benign treatable condition we have on the left-hand side. So what does the data say? Well, look, age is important, certainly. For gastric cancer, it's still more of a male predominant condition, but over 50 we worry. So that patient had a T2N0 M0 cancer. And then reflux, which I think there's a lot that we can talk about reflux, both in terms of reflux of Barrett's, reflux management, and so on. So reflux alone in the younger patient population, again, has a very poor yield of cancer diagnosis. You can see reflux as a single symptom, and no one really worries per se about reflux as a symptom of cancer. It'll be reflux potentially leading to other symptoms later on. But then certainly age is an important factor. It increases. It doesn't quite make 1% afterwards, but it's increasing in an older age group. So what to do with chronic reflux? I think a lot of you right now will get a lot of resistance from gastroenterologists about reflux, and I think a lot of us, I know I speak to my colleagues, and this is an open forum for us to share. I think a lot of gastroenterologists are trying to push reflux into the community, and Ruth will have some answers about what we can do together to investigate reflux. What I would say, I think all of you would start a patient on a PPI, and then afterwards, I guess you assess the response, and maybe when they don't respond, you might send us a letter to say, well, now is it worth an endoscopy or something else? Because it's correct at that point in time for us to think, okay, even if we're not going to do anything endoscopically, does this person have Barrett's? Barrett's is really important to work out. Or actually, even if me as a gastroenterologist, if I can't treat this, then can I send this to an upper GI surgeon to do an anti-reflux operation? This is one of my favorite slides from an old boss of mine, a chap called Thomas Seuferlein, who's I did a fellowship in Germany. He did some really cool, he sprinkled PPI on cells. And he did this study, which has been a game changer in my practice, that not all PPIs are created equally. And I'm starting to see this more and more clinically. And some of you that get letters from me and think I've gone mad when I ask you to put the dose up of pantoprazole to 40 milligrams 3 times a day or something like that. I haven't gone mad. This is the reason behind it. But apologies if you do get letters like that from me. It's for this. So just to walk you through this, this is omeprazole 20 milligrams. He's compared everything to omeprazole 20 milligrams. So there we go. 20 milligrams of omeprazole is equal to 20 milligrams of omeprazole. 20 milligrams of pantoprazole is only equivalent to 4.5 milligrams of omeprazole. So therefore, you could do the maths. 40 milligrams of pantoprazole is only equivalent to 9 milligrams of omeprazole, and 40 BD is only equivalent to 18 milligrams of omeprazole. Pantoprazole, therefore, is really well tolerated. I've got to be honest. In fact, in many ways, it's probably the most or the best tolerated PPI. But actually, in terms of efficacy for symptoms, isn't very good. It's cheap though, and I think if someone's got very mild reflux symptoms, it's reasonable to start them on this. I guess where I'm going with my thought process on all of this really is that I think it's been my practice, and it's something I wanted to share with you, and I'm very happy for you to, because I can't see you now, I can only see my slides. I don't know whether you've got your pitchforks out yet, but I think it would be reasonable to say if someone fails one PPI, you could certainly try a dose increase, or you could move up this ladder from pantoprazole to lansoprazole to omeprazole, and so on and so forth. And I think that's reasonable to do. If you've tried one, then try another. And then I think at that point in time, we can say they truly have failed their PPI. But I think sometimes we know that that change might work. There's one other thing that I guess I'll just tell you, and not to bore you with the science of this, but it's the interesting thing about these two on the ends, the pantoprazole and the rabeprazole. I don't think rabeprazole, even I have to fill out some paperwork to prescribe rabeprazole. So I'm not sure. I think I've got 1 or 2 patients in the community that are on this, but it's really hard work for you and me. But one other thing is that these PPIs, the common ones we might prescribe, lansoprazole and omeprazole, are metabolized by one of the cytochrome P450 enzymes, CYP2C19. And there are a group of patients that are hypermetabolizers. So in other words, you give them their PPI and immediately they just kind of burn through it and they have no effect. And so in that group of patients, sometimes they're the ones that I say to you, and I sound a bit mad when I say give it 4 times a day or something like that, because actually they're a group of patients that if you give them a PPI very frequently, then over a 24-hour period, they will get some benefit. Pantoprazole is not metabolized by that. So I think it might be reasonable to start with pantoprazole, because if it doesn't work, then you don't need to worry. You can move up to one of these other ones. I tend to probably skip to omeprazole straight away. And then if that doesn't work, I'm using esomeprazole. Rabeprazole also is not metabolized by 2C19, but it costs so much that I think, it's just not worth the work behind that. And then one of the other things that you deal with probably more than me, but it does come up in my clinics and my endoscopy rooms, but the patients Googled and they've thought, God, all these side effects of PPIs, what am I going to do? This is a really nice paper which is really readable. It's published in a gastro journal, Frontline Gastroenterology, but it's kind of it was written as an idiot's guide for the jobbing gastroenterologist who has a patient there who has a whole list of questions about the side effects of PPIs and whether it's safe or not. I don't have the data behind that, but please have a look at the paper. But as I guess the kind of conversations I have with patients is very much, well, look, if you've got Barrett's esophagus, then I'm sorry, the data shows you benefit from being on a PPI. It will protect you from developing cancer. The one study that looked at that in great detail is a bit of a worrying study. It's called the ASPECT study. It looked at a dose of esomeprazole 40 milligrams twice a day. Again, that's a big dose of a big PPI. It showed that was significant. No one's looked at other PPIs at smaller doses, but I guess the idea is it divided people into high dose PPI or low dose PPI, which was esomeprazole 20 once a day, I think. And a big dose of PPI helps people. So patients with Barrett's, they need a PPI. We haven't quite worked out for what dose yet. I'm not asking you to prescribe 40 BD, but I think they probably should be on a PPI and maybe then at the lowest dose that controls their symptoms. For everyone else, again, we start them off and I guess we try and wean them down. So I have that conversation. I say, look, if you've got a condition, either you've got horrible heartburn, you need a PPI, fine, you need a PPI, or you've got a pre-malignant condition like Barrett's, in which case, hey, you need to take a PPI. For everyone else, then, I say, if you've got concerns, don't worry, the benefits probably outweigh the risks, either from a symptom point of view or from a precancerous point of view. But the risks are actually probably overstated. Yes, there is clearly a risk of enteric infection, but you've probably got hundreds, if not thousands of patients with PPIs. They don't all have Clostridium difficile. If they've had it before in the past, I think we need to have a little bit of a think. But in a younger patient, certainly, who probably has a good gut microbiome, you don't need to worry so much about C. diff. I think you could give them a PPI. I think we worry a little bit about that there's data to show the risk of osteoporosis exists. Again, what I do for my patient group is more and more I'm kind of reviewing things, but the risk of osteoporosis doesn't happen overnight. It happens maybe over 5 years or so. So if they have risk factors for osteoporosis, I might do a DEXA scan and query whether I can continue their PPI with some bone protection, or if they're on their PPI and I'm committing them to it long term, like our Barrett's patients, then I might consider a DEXA scan for them at some point, probably beyond the 5-year point. There is some data to show that it can upset some of the salts, in particular magnesium. And I am either personally checking or I have some kind of shared care agreement with primary care to check Usinase and magnesium on a maybe 6-monthly basis. Again, there isn't data for that, but it seems to work okay. The risk of hyponatremia is overstated. One really cool fact to tell you, that seems to be limited only to omeprazole. So if they're on another PPI, don't worry about their sodium. If it does drop, it's not their omeprazole. And then the risk of dementia is as yet not proven. And I tell my patients that the risk of gastric cancer and colonic cancer is unproven. There is data of association, but not causation. And I'm very confident telling my patients that. But this paper gives you the risk ratios and all of that stuff. I think I'm finishing now, but I guess Ruth is going to talk a little bit about what I think may be a real game changer for us that can help us to pick at the patients that we're all still going to worry about, the younger patients who the data and my gastroenterology colleagues are going to say to you, don't worry about it, they haven't got a cancer, or that, they probably won't even have Barrett's. But we know we've all seen at least one case of a young patient that's had a malignancy or something that shocked us a little bit. So what can we do for these patients? And she'll mention that. I won't steal her thunder. I'll just finish off here with some take-home messages. I think the cancer dysphagia score is going to become more and more of a common thing that either we will be embedding into secondary care. We might be asking primary care colleagues to support us in its calculation, or we'll work out some way on how to do it. But I think we probably are going to be using that just because endoscopy is in such a dire state in terms of our waiting times. I think currently NG12 is pretty good otherwise for kind of other conditions and the dyspepsia types of patients. I think all I was really say is don't worry about checking H. pylori status. I'll let Ruth talk about capsule sponge. Irritable stomach or functional dyspepsia. I think still in practice, even if you wanted to keep them in, or it wanted us to review them in clinic, it takes a very brave gastroenterologist, especially in a patient maybe 50 or older, to say, I'm not going to scope them. So even though there are guidelines that say don't scope these patients, guidelines are guidelines. They're not the law. And I think we all know that we probably need to think about it at the very least, although their prioritization may not be, it might be on a more routine pathway. So I'll stop there, I guess, in the interest of time. I don't know if I've overrun. I don't know. But anyway.
Did really well. I mean, I sort of say, wow, I think it's such a lot that you've covered. And I think, speedily through some of them, that has generated a few questions. I don't know if you'd be prepared to share your slides with people afterwards, whether you want to remove any of the ones with Cardiff data or stuff that you're not necessarily keen to spread around. But either way, I'm sure people will be asking if we could have a copy of your slides.
In many ways, it's probably helpful that you know how bad things are in Cardiff, so that when you're waiting for your OGDs, you're thinking, now you know. So yeah, it's not a problem.
So, but just, I'm conscious of time. We've agreed to sort of conclude the meeting by past. I know Ruth's going to bring a primary care perspective to this, but I'm just going to ask you a couple of questions that have come up in the chat, Hassan, and then pass the mic to Ruth, if that's okay. So a couple of things basically about H. pylori testing. So how soon after eradication therapy can you check the stool again? And how long should you stop the PPI before the stool test, which I know you touched on briefly, but just for clarity, please.
Yeah, really good question. So if you get an endoscopy report from me, it's really wordy. I'm sorry. So what I do is I say, I've diagnosed Helicobacter pylori. Nearly always I'm good. And I will have started a treatment. There's data to show that 2 weeks treatment now is better than 1. And I think there is increasing clarithromycin resistance. So just so you're aware, and I don't have any shares in metronidazole or amoxicillin, but I give 1 gram BD of amoxicillin, metronidazole 400 milligrams BD. There's data to show that high dose PPI works better than lower dose. So I give 40 milligrams BD of omeprazole and I give it for 2 weeks. And then I say, that's your 2-week course. Then you stop everything. And if they're already on a PPI, I ask them to hold their PPI after that for another 2 weeks. And at that point in time, then, so after stopping eradication, it could be 2 weeks afterwards. And after stopping PPI, it could be 2 weeks afterwards. And ask to check the stool antigen. And sometimes you get these really annoying reports from me, I'm sorry, where I say, also, could you consider checking the stool antigen in any co-inhabitants? I'm sorry if you've got those. The reason being that we do have a group of patients who are more and more we're seeing people coming back, or it's certainly helpful in patients who you do a stool antigen, they're still positive, because rather than them having a true resistant infection, they could just be getting reinfected by an otherwise less symptomatic co-inhabitant. They share the same glass water or cup of tea or whatever it might be, and so it's just a thought. It's kind of made it into epidemiological data, but it isn't something that we're routinely. I'm rogue from that bit of advice, but that's what I do.
I didn't know that. That is curious. I've never seen you write it, so as it's so far so good. But I guess from a primary care perspective, pre-endoscopy, how long should we be stopping the PPI? You did mention maybe not needing to do it at all in the talk.
Yeah.
So if someone's on a PPI and then we want to do an H. pylori test, would you stop it for the test?
No, I'd be happy to continue. Again, in Cardiff, we discussed this locally, and we were happy for GPs to continue PPI. That isn't the case across all of Wales. I know I've been in a discussion advising Swansea. I think they hold PPI for 2 weeks, and then there's this really annoying, quirky bit of advice that some of you will be getting, because gastroenterologists like to be odd. And if someone's got dysphagia and we're worried about eosinophilic esophagitis, so a benign dysphagia, then we're asking you to hold the PPI for 3 weeks. The PPI seems to give a false negative results for eosinophilic esophagitis, and 3 weeks seems to be the magic number. But again, I mean, if you've got dysphagia and you're on a USC pathway, we're all getting told off if they're waiting 3 weeks. So, but that's, I guess if they're not on a USC pathway because they're a younger patient, you might get away with that.
Okay. So if we can, a quick one, if possible. So how long is the shelf life of a previous normal OGD? So when would you advise to repeat it? So I think that's when we all get the EBGBs that, well, they had one last year and it was okay. Like, is it, is there a kind of caveat that you would say if it's been over X amount of time?
Yeah. So the Pujic data is 3 years. That's what we're looking at, in terms of the risk. I think that's a safe place to start. But I think there is an element of, so if you get the report and it says the patient struggled, or, the mucosa didn't look so clear, or, something else like that, I think just query it with us, because we sometimes do that. And, we sometimes look and see who scoped the patient. Nothing against trainees, but was it a trainee? All these other kinds of things. I think you can raise that query. But otherwise, if you're otherwise reassured, but the patient's coming back to you, 3 years seems to be the kind of shelf life that we might go for.
Fabulous. And the final question, as yet, we may get some time for some at the end, would be what role does famotidine play? Are we using any H2 antagonists?
We are. It seems to have good data for symptomatic relief. It doesn't affect Barrett's. It doesn't affect risk of cancer. So I use it, and it seems to work really well for nocturnal reflux rather than kind of daytime reflux. So I tend to use it as an adjunct in patients that have lots of nocturnal reflux, 20 milligrams at nighttime. We don't use it for Barrett's prevention unless the patient really can't tolerate a PPI.
Fabulous. You know, round of applause from everyone in the audience. I'm sure we've all been completely, you know, mesmerised and inspired by that. So thank you, and thank you for being so approachable as well. 20 minutes to go on the clock, so I'm going to pass the mic to Ruth. But if you're happy to stay on, Hassan, there may be some questions that come up on the end that, you know, after Ruth's done her update as well. Thank you, Ruth.
Thank you, Elise. So from my point, Hassan, please do stay on because I know you'll be able to answer all the questions that I can't. So I hope you'll stick around. So I work as a GP in an IRA in Bevan, but work more sort of with cancer services in Powys, and then with Hassan with upper GI cancers. So I will share my slides. As Hassan has said, I am mainly going to talk about the capsule sponge testing. So I'll just put that onto a slideshow. It goes on. Can you see that okay, Elise?
Yeah, it's showing well. Thanks, Ruth.
Yeah, lovely, thank you. So the capsule sponge testing is the first innovative, I suppose, diagnostic test that's been rolled out across Wales that I'd like to talk about. You may hear it by its brand names as the endosign test or the cytosponge. And it's a minimally invasive test. And the key points really to note about it are that it doesn't require any sedation. It can be performed in any care setting, so anywhere where a patient can swallow a tablet with a glass of water, really, in the community or in hospital settings, it can take place pretty much anywhere. And that we've had good feedback on patient experience that generally it's very well tolerated. So as Maddie was talking about with the 10 of us paper, esophageal cancer has poor survival rates. And one of the main reasons for that is that 80% of esophageal cancer is diagnosed at a late stage now. So you can see from the pie chart that if it's diagnosed at a late stage, there's only a 21% 1 year survival rate. Whereas if we could flip that and diagnose it early, those who are lucky enough to have their esophageal cancer diagnosed early get an 84% 1 year survival rate. So from that, you can see that it really is key to improving survival is earlier diagnosis. So we really need to be diagnosing these patients earlier. Barrett's esophagus, as has been mentioned lots, is the known precursor to esophageal adenocarcinoma, which is the majority of esophageal cancers. Now, we know that we have so many patients with dyspepsia and gastroesophageal reflux symptoms. It's cited that it affects up to sort of 5 to 20% of adults. And then about 3 to 6% of those people with reflux symptoms have Barrett's. I've also seen 5 to 10%, but it's in that realm. But we all know that we all have patients with reflux that we're treating with PPIs in the community, and most of them we don't refer on for endoscopy because there just isn't the capacity in the system, and it doesn't fit with the guidelines now. So less than 20% of people with Barrett's esophagus are actually diagnosed. So 80% of the people walking around with Barrett's esophagus don't know that they've got it. And that's quite a key point. So just to show you how easy this sponge test is, I'm now going to stop sharing and show you a video that's on the CytEd Health website. So I'm sure I'm allowed to show it because it is there. Oops, sorry, I've gone on to that.
I don't know if we've actually lost Ruth with that, whether she's managed to leave the meeting instead of sharing the screen. Give a moment to get back on. Hassan, I don't know if you're in a position to answer a question while we wait for Ruth, or whether yeah, you're still there. Fabulous.
I'm still here.
I'm sure she is now coming back in. I guess my question, just while you're waiting, I'll let Ruth just get her video up. But I guess it was going to just be around H. pylori in general and kind of stool testing, and I guess a slightly controversial one. Would you recommend like sort of fit testing? Like what's the current perspective on fit for sort of upper GI symptoms like that? Would you, because when we it feels like we give them a load of stool pots in primary care when they send them on their way, and you know, how helpful is it in line with everything else? And,
yeah, I mean, look, I'm a gastroenterologist, so we're obsessed with poo, aren't we? So we're very happy for you to give these patients all of these. But I think the data doesn't seem to be there. So we've had a group of patients, very understandably, we've had a high fit, a normal colonoscopy. Well, where's the fit coming from? Or they've rechecked the fit, it's still high. There doesn't seem to be any good yield of doing an upper GI endoscopy on these patients. And in terms of, we haven't found any sinister cause for that group of patients. So I think you could be reassured and not do an OGD on them.
Okay, fabulous. Thank you. Ruth, we lost you for a bit, so I was just giving Hassan a moment just to fill with some questions we had, but are you back on now?
Yes, I'm back on. Sorry, Elise,
okay.
I clicked the wrong X on the screen.
You're okay, no problem.
So I hope you aren't panicking too much. So this is the video of the endosign capsule sponge test being done. There is no sound on it because there's no sound when it plays online either. So I'll just talk over it. So this is just a short 45-second video, which I hope now runs nicely. So this is the applicator that the endosign comes in with, the little capsule with the sponge in it. So you have the capsule and the rolled up or sort of folded up string that's attached to it. So the applicator just drops it on the back of the patient's tongue. Then they just take a nice big gulp of water, swallow it down through the esophagus. And then once it reaches the stomach, after about 7 minutes, the capsule dissolves and you've got this little round sponge pops out, and it's ready to be pulled back up through the esophagus by the string that it's attached to. And the idea is that it just collects those cells along the way. Out it comes, pops into the pot, and goes off to Cyted for analysis. So I hope this works a lot better now when I stop sharing and go back to my slides. And I'll go back and share the next slide. And fingers crossed that works. Can you see that now, please?
All good, yeah.
So with these capsule sponge tests, as you can see from the video, they're really easy to perform and it's easy to train up to do them. And they can be done in the community as well as in hospital settings. And in Paris, we've done them in sort of community hospital settings with our implementation study. So they've been given different uses. They started being used mainly mainstream in Scotland back in 2020 in COVID to triage their endoscopy lists. So they can be used for triaging patients with reflux symptoms awaiting endoscopy to reduce those waiting lists. They can be used in surveillance for people with known Barrett's esophagus. And they can also be used for case finding patients with Barrett's, because as I mentioned, less than 20% of people with Barrett's esophagus actually know that they have Barrett's. So there is work being done on finding those other 80% of the people with Barrett's esophagus so that we're aware of them, as Barrett's is a pre-malignant condition, so that we notice, have them on PPIs and monitor them with surveillance that it doesn't progress to anything else. So when that sponge goes off to the lab for analysis, there are 3 things that they're mainly looking for in the lab. So there's the trefoil factor 3 or TFF3, and that is an indicator for intestinal metaplasia, which is Barrett's esophagus. But they also look for the biological marker P53, as that's a marker for malignant transformation. And if we remember back to our uni days and those pink and blue slides, the H&E staining, and they also use that then to look for cellular atypia. So if they do find that there's P53 or cellular atypia, then that is reason for someone to have urgent endoscopy, as in an urgent suspected cancer endoscopy. if they only have TFF3 and don't have any sign of P53 or cellular atypia, then they can go on to have routine endoscopy or surveillance, and that will vary then between health boards and at what stage we're at as to whether they can wait till they would have the next interval between for surveillance, or whether they would go on to a list for routine endoscopy. The other test then that I wanted to let you know about from a primary care point of view to be familiar with is transnasal endoscopy. So as you can see from the picture here, transnasal endoscopy is the alternative to that traditional transoral upper GI endoscopy. And you've got a thinner scope that goes through the nose in the patient. They're sitting up there. They don't need any sedation, and it tends to be much better tolerated than transoral endoscopy because it does bypass the gag reflex. So it's really nice that the patients can speak during the procedure, and Hassan certainly does a lot of transnasal endoscopy now. One of the other advantages is that it doesn't necessarily need to be done in the endoscopy suite itself, and you don't need to have that recovery time for patients who've had sedation either. And we are working hard at rolling out both transnasal endoscopy and capsule sponge testing across Wales. So I've just put up this slide to let you know where these things are happening now. So with the capsule sponge testing, that's in place now in Aneurin and Bevan. Betsy are doing a lot of capsule sponge testing, Cardiff and Vale as well. Cumtaf. In Powys, we've done an implementation pilot, so everybody's trained up to do it, but we don't actually have a service running at the moment, but hopefully we will get that back up and running again. So you can see that there are a couple of health boards missing from there, Haldar and missing the other one there, Swansea Bay, for the capsule sponge testing. And then on the right, you've got the transnasal endoscopy. So that's up and running a lot in many places, thanks to Hassan running around the country and helping to train up people with doing transnasal endoscopy. So we've got it up and running in Aneurin and Bevan, in Cardiff and Vale, where Hassan is. Cumtaf are doing a lot of it in Powys. I think we're probably doing more transnasal endoscopy now than transoral. And in Swansea Bay, they are doing occasional transnasal endoscopies, but generally they're transoral, but we haven't got it running yet in Haldar or Betsy, unless Hassan knows differently. But I just wanted to give just a quick overview really to show you, I suppose, to familiarise primary care with what is out there, what's sort of new in Wales from the point of view of the capsule sponge and the transnasal endoscopy. I think the capsule sponge is more important for us to be aware of because of its setting in the community, the fact that it's not highly skilled, you can train up easily to do it, and generally it's nursing staff that are performing the capsule sponge testing. So it's something that there could be a place for in primary care and in the community setting. And there is the Best 4 trial going on at the moment, looking at its use in the community. But I might let Hassan talk a little bit more about Best 4 and where it's for at Wales, because he's actually the principal investigator for the Best 4 trial with capsule sponge testing in the community for Wales. So mine is very short and sweet, so that we'll have some more time now for questions and discussion, and I'll stop sharing.
Fabulous. And Ruth, I guess my question to you may be, one to both you and Hassan, really. I guess, it's the volume of numbers, isn't it? It's a direction of travel and how accessible these tests are. I guess, is there an option of actually being very much community-based, practice cluster-led or whatever down the line, doing, say, capsule sponge? What's the kind of transfer time to get samples to the lab and stuff? Is it something that's realistically able to be open to community use, or does it need to be more like a DGH kind of hospital setting?
No, I think it would work on a cluster basis, certainly, because the way that it runs is CytEd then CytEd. If you use CytEd, does all of the lab work for all the lab analysis, and Endosign is the CytEd capsule sponge test, but there is also the cytosponge available as well that was around before Endosign. But all of the they're all analysed by the CytEd lab. So CytEd would organise collecting the sponges and bringing them to the lab and doing the analysis. So you'd want to have a reasonable number together. You'd want to be bunching them probably, rather than thinking, well, I'll do a capsule sponge today and I might do another one in 3 weeks' time.
Yeah.
But logistically, I think it would be better to be sort of bunching them together so that you had a number to go off to the lab together.
Yeah, and I guess, similar to the lung cancer health check, is there a kind of move to doing like a section of the community and looking at risk groups and stuff, well ahead of when symptoms develop would be, an exciting prospect, wouldn't it, to try and target some of these, dreadful numbers that have been presented across the evening in terms of survival rates for late diagnosis of esophageal cancer.
Yeah, because it's not only the better survival rates if we diagnose it early, but it's also so much easier to treat. So that sort of when you're at the dysplasia or the really early esophageal cancer stage, then that can be treated endoscopically. So it's a massive difference for the patient if it's diagnosed early. But I might let Hassan come in and talk a bit about best for, because that is about using cytosponge in the community for screening, and for they have a surveillance arm as well. So if Hassan wants to come in and talk a bit about best for.
Yes, I'm happy to. Best for is a study, as Ruth alluded to, is a community study of capsule sponge testing, right? And the idea is that patients with reflux symptoms can self-refer, but by all means, you all can direct patients to this. This is probably going to start in March of next year, but there'll be a mobile unit currently that will be moving its way across the whole of Wales. We're hoping all of Wales will be covered, but there is one small caveat to that, is that everyone seems to be terrified of the chance of a sponge getting detached. It's a sponge, but anyway, because it's a research study, and the risk of sponge detachment is about 1 in a million, or estimated to be 1 in a million. They haven't done 1 million tests so far. They've done 13,000 of this new device, and they've not had any detachment. So it's pretty good. But the caveat to where this gets tested is that it needs to be within 30 miles of a hospital that could retrieve the sponge within a 6-hour time frame. So we're hoping that all of Wales will at least have the option. Patients might need to travel naturally, but where the mobile unit will be somewhere within an endoscopy unit that could deal with a detached sponge. And it's gonna look to see what the chance of picking up Barrett's is in the community, and what the chances, I guess, of picking up dysplasia in the community. The capsule sponge test has been looked at in secondary care. It's been shown to be very safe. It's been shown to be much better tolerated than endoscopy. I saw some comments in the chat about cost. It's obviously a sponge on a string. It's cheaper than endoscopy. It's still expensive though. I think it's about £200, isn't it, Ruth? About £100 for the sponge and £100 for the analysis.
Yeah, it's about 280 maybe for all of it.
Yeah. Oh, there we go.
The last figure I saw.
It's going up. But it's still cheaper than endoscopy. And it's been shown to be excellent at diagnosing Barrett's, and it's really good at diagnosing dysplasia. It's not perfect, but actually, I kind of joked about this earlier, and about how endoscopy is considered the gold standard. But if it was the gold standard, we wouldn't have this thing of post-endoscopy upper GI cancers, these Pujics that we're seeing. By the way, the Pujic rate, there'll be other data for another day, which I'll share. I've shared too many of Cardiff's awful results, but across Wales, it varies up to 10%. That's not a good number at all. So I think having a test that at least standardizes the analysis for a group of patients who potentially have lower risk, because someone that's high risk is going to have an endoscopy on a USC pathway. But for that lower risk group that we're all terrified about missing something, or we want to pick up something pre-malignant, I think this could be the future. I think we need to prove that it works in the community and that it's safe. And I saw another comment about, can the sponge just pass through? I think it probably can, but because no one's ever done a study on how safe it will be, and no one's volunteered to have the sponge, the string cut and let the sponge pass, no one knows. It'd probably be absolutely fine going through the stomach pylorus. the main concern is whether it might get stuck at the terminal ileum just entering the colon, and that's a slightly narrower valve. I mean, people swallow coins and they pass through, don't they? But anyway, it's not been done, so we don't know. So yeah, sorry, we have to.
I guess it's a
retrieve
lack of willing medical student volunteers these days, isn't it?
Yeah, tough times.
There was one question that I think possibly hasn't fully been excellent, which was what's the sensitivity specificity of the capsule test? And we did talk about the expense of it. So is sensitivity specificity in terms of stuff it pulls back? Are we happy and confident that that as yet proves to be a useful task?
There are different results still quoted. Mainly, Ruth might know the data a little bit better than me, but mainly for two reasons. That there's a really nice paper, Ruth actually very kindly reviewed this paper, that showed that there's a bit of training to it as well. And so you start off with adequacy rates of about 60%, and they can go up to about 90% or so, but with just being more skilled. So some of the secondary care data seems to be very good and comparable to endoscopy. I don't have the exact numbers, but certainly comparable to endoscopy. I guess best four is going to tell us in the community, is that different? I'm sure it won't be. It's still swallowing a sponge, but that data is to come. Fabulous.
Well, not wanting to overrun for anybody's sake, but particularly in an evening. I think we've covered the questions in the chat, so I'm going to leave up a sort of feedback slide from the RCGP, who, like I say, who have kindly supported this with Velindre Oncology Academy. A huge thank you from everyone in the audience who's listened, but also those who will pick up and watch the recording back down the line, to all the speakers, to Maddie, to Hassan and to Ruth. I appreciate, it's really generous of you to give your time in an evening, but you've also done some really, amazing work and, future thinking work that hopefully, for our patients and our loved ones and relatives who may need these tests, let's hope there's an improvement in cancer diagnostics for upper GI cancers. So yeah, very big thanks from us. My colleagues Mick Button and Fiona Rawlinson have helped as well get the show on the road today and delivered sessions with me in the past, and will continue to do so. We've got a pancreatic cancer update and a lower GI cancer update coming to you before the sort of first week in December. So look forward to seeing some of you then. Thank you very much.